Yes, very well.
Excellent. Let's get started then. So in this case, it's a 4-year-old female. She was born with optic nerve hypoplasia in both eyes. Originally, she saw a specialist who thought there was some discoloration in her macula. And when you, Dr. Cohen, ended up seeing her, there was some scar tissue in the left retina and asked her to come to get evaluated. The patient has nystagmus, which has improved. She's also very farsighted and is now seeing pretty well with her glasses. She's also had esotropia for a long time and was originally diagnosed in Kansas with eye problems, and she moved here from Kansas 7 months ago. So overall, just some nystagmus, very farsighted, and visual acuity, has no evidence of fixation.
So I just type as the patient's talking, not the patient, I guess it's the mom. So, so they were talking, so I wrote this all down. So some of this may or may not be true.
Okay.
So just keep that in mind as you go through the case.
Like the mom saying she sees well, but then she can't fixate.
Right.
Okay.
And also even the diagnosis, that's what the point, like the optic nerve hypoplasia. They said, yeah, he has optic nerve hypoplasia, can't see well. Somebody's worried about the retina. Thought I should take a look. And so that's the history. But it doesn't mean it's right.
Okay, so we have an external photo.
These are
of
from
a young
basketball.
child
Yeah.
of the right eye. Speculum is in place.
You guys
She
are
is
pretty
farm
used to this.
dilated. In the lens, it looks like there's some kind of opacity. It's hard to say if it's like anterior lens, posterior lens, just from the photo. Good red reflex, at least.
I agree. I don't think I have anything to add to that. And then here we go.
So left eye external photo. Here it looks like maybe there's some kind of, I guess, like cortical or maybe anterior lens capsule. It's hard to tell from this photo, but looks like some lenticular opacities, but also good red reflex in this eye.
Excellent.
Okay, so we have a color fundus photo of the right eye. The media looks pretty clear, I guess. The nerve does look a little bit pale, but it does seem to have some sharp borders and then maybe some PPA surrounding it. Overall, there's a pretty kind of blunted, kind of entire macular reflex. Just not clear imaging throughout the macula. And attention is towards the kind of temporal aspect. There's a maybe like 0.5 DD kind of round atrophic appearing lesion with a choroidal vessel underneath.
The only other thing I'll add is he has a lot of kind of pigment out here in the periphery, as well as kind of increased pigmentary changes in the macula. And then here's just another kind of photo showing that atrophic lesion that you were talking about, and a little bit more in the periphery.
Yeah, the pigmented spots are much more evident in that photo too. And then just a nasal kind of picture of the right eye, so you can certainly see see more of those pigmented spots in the periphery.
Excellent.
Okay, so color fundus photo of the left eye. So overall similar that the nerve looks pale. There's looks like PPA around it. Just kind of diffuse pigmentary changes throughout the entire macula with maybe like a 1.25 DD round-ish kind of atrophic appearing lesion in the macula involving the fovea, and then more of those pigmentary areas out in the periphery.
Excellent. And then same thing. You basically said just a little bit more zoomed in on that possible atrophic area there.
And then just a photo more of the temporal retina.
And then inferior here, you're just kind of seeing more of those pigmented spots. All right.
Oh, geez. Okay.
I know, I thought the same thing when I saw that.
These
You
are-
never explained
these are
that.
my
It's like the
favorite
Spanish Inquisition.
pictures grade. Okay, so.
Are you Googling ERG? I have to Google ERG. Right.
So all I know is that an ERG is supposed to have
Do
an
they
A
bring
wave
these
and a
to
B
you, like in a
wave.
giant stack of
I
200
sent them to
pages
Miami.
to look at during your visit?
No, I sent them and got all this done.
Oh,
Okay,
good, yeah, that's helpful then.
Mm.
so, I don't see a good A wave. I don't really see a good B wave either, so reduce amplitude of both.
So your different responses. Are you gonna talk about the ERG, Courtney?
I mean, a little bit, but I'm still not great at it. I spent a lot of time trying to look it up and read about it as well. The main takeaway that I got, kind of like you said, there's supposed to be a good A wave and a good B wave. You have just the rod response, then you have a combined rod cone response. It's kind of based on how bright the light is, if I'm not
You're
mistaken.
dark adapted. So for the rods, you would have to, you got rods and cones, right? So your rods are your night vision, so you'd have to dark adapt the kid. So basically you put the baby in the dark for a while, I think a half hour, I guess, or 45 minutes with its mom, hopefully. And then you shoot the light real quick. And once you shoot the light, they're no longer dark adapted. Doing an ERG is a pain in the neck. So the rod response is dark adapted. The combined rod cone is probably just in the light, I imagine. And then the oscillatory potentials are supposed to give you an idea of your cones because the oscillation kind of dampens out the rods. I'm at 90% sure that's all correct. Not doing ERGs.
What I gathered from this is it's just kind of overall poorly responds to kind of any of the rods or cones in both eyes. So an overall extinguished ERG.
It's supposed to go down, go way up and then over it, like a broad EKG.
And then again, there's really not too much difference here. There's just some more flashes, and you can see just kind of poor response overall to any type of light response in both eyes, in the rods and the cones. So finding summary, it was a 4-year-old girl who was originally diagnosed with optic nerve hypoplasia in Kansas. Her fundus exam in her right eye, we saw all those hyperpigmented lesions in the periphery of the retina with kind of a marbled appearance. She also had some hyperpigmentation in the macula, a little bit of optic nerve atrophy, and that area of atrophy in the retinal periphery. Her left eye, she had some hyperpigmentation again in the periphery with kind of that marbled appearance, optic nerve atrophy, and then that hypopigmented area in the macula. Dr. Cohen, was that flat or elevated? Do you remember in her? Was it like scar tissue or was it just atrophic?
I just atrophic flat kind of.
Okay.
Yeah, flat and atrophic.
And then for the ERG, the general consensus is just this nearly extinguished ERG in kind of both eyes. It doesn't have those good waveforms like it's supposed to. Oh, sorry. What would be your differential diagnosis?
So RP, especially with like the nerve hypoplasia, PPA, and then those peripheral lesions.
But was there wasn't really nerve hypoplasia. That's why I think that was just
Oh,
wrong.
really? Oh, okay.
Yeah, if you look at the nerves, I mean, if you go back, those nerves I think look pretty good.
I don't think it has that waxy pallor.
I think it kind of, I don't know. It's hard to tell because it's kind of like fuzzy, but I thought it looked a little pale, but.
Well, you're gonna get pale when your retina's wiped out, but I think the size is not bad.
Yeah.
Yeah.
Hypoplasia has a double ring sign you look for?
Yeah, and also just kind of small. So I think that was just a misdiagnosis.
And then you could just say in general, any rod cone dystrophy, any rod dystrophy, any cone dystrophy.
Yeah, nowadays, I think it's mostly IRDs, inherited retinal diseases, is kind of taken over a little more from dystrophy. So yeah, so dystrophy, inherited, yeah, just there's something wrong with the retinas.
And that's probably my differential.
That's good. Only thing I added kind of some odd ones out there, just optic nerve hypoplasia, retinitis pigmentosa, any type of the inherited retinal diseases, congenital rubella, congenital stationary night blindness, achromatopsia, any types of the paroxysmal or paroxysomal, oh my goodness, I can't speak, disorders, and then any of the ciliopathies as well. So we did genetic testing on this patient, and they were found to have Leber's congenital amaurosis type 9. So I'll be talking a little bit about Leber's congenital amaurosis.
So Steve, can I ask you a question?
Sure.
So, actually, I'm so curious how you got this patient set up at Bascom for this sedated ERG. That's amazing. But would you have considered just genetic testing in the office without the ERG?
Yeah, but it's, well, it was a baby though.
It's hard to use.
So I don't know. Like, that's why I'm sort of looking at this baby thinking,
Let's say this
I don't know.
let's say this was a 45-year-old who came into your office and has never been diagnosed, and the wait time for an ERG is 4
Oh, yeah, I don't
months.
get
Would
ERGs.
you-
Yeah,
Would
I
you
don't
just
get-
genetic test?
Yeah, genetic test,
Okay.
yeah, genetic test. In fact, mostly I kind of wanted them, although it was funny, the thing is, this kid came with an optic nerve diagnosis, the mom's understandably anxious.
Yeah, of course.
And so it was a change in diagnosis too.
Of course.
But but mostly I wanted the EUA and the blood test. And Bascom would do it, which was nice. I kind of wanted the pictures. For teaching. The stuff I do.
You correspond
What's
with
that?
with
Yeah,
Nina?
Byron.
You got him?
Yeah.
Or-
I think
or with-
Byron did it.
Or
I think Byron-
Byron Lamb,
Yeah, I
yeah.
think Byron
yeah.
did it.
You corresponded with
Yeah.
him and he sent you
Yes,
all this
I
stuff.
think
Because
I
when I
did.
send people to Bascom, I sometimes get like a okay letter back, and
Yeah.
mostly I get nothing but have to contact.
I have
them.
a couple contacts, so.
It's,
I think you have to get patients in, you have to contact the secretary of whoever
yeah,
you're trying to.
secretary if you're trying to get them.
So I have
And
like
they're not
Basil
many reasons
Williams.
to send them down there. This is a good reason to send them down there. Sometimes,
Yeah.
rarely uveitis with Tom.
And I think I told them, I said,
Yeah,
we can
thanks.
do an EUA, we can do the blood under anesthesia. But if you can get to Bascom, they could do a little more. Yeah, I don't know, I don't think you can do babies.
For adults,
Yeah,
I think.
can you do babies? though? You can do babies.
I don't know if.
I would bet you can do babies.
Because then they would have to sedate.
Yeah,
Maybe that's.
yeah,
That's gonna get it one.
yeah, a baby,
Wow.
okay, okay, because I've sent people, I do ERGs here, this is where I send my ERGs when I send them.
On the guy said he did it.
Okay,
It's all ones.
yeah,
Mhm.
all right, so go ahead, Courtney, you're doing great.
All right, so just some general information on this first, then we'll go into a little bit more specifics. So it's a rare severe inherited retinal dystrophy. It primarily affects the functioning of like the rods and cones, as we saw in that ERG. It's characterized by severe vision loss, usually starting in infancy, nystagmus like our patient had, photophobia, high hyperopia, which our patient also had, and poorly reactive pupils. In most cases, it leads to blindness by age 1. And in infancy, it's usually noticed because parents, usually the literature said around 6 months, parents start to notice that there's like a lack of visual response in their infants, which kind of prompts getting seen by a specialist. And then this is from the BCSC that LCA should be considered in any infant suspected of poor or declining vision if there's a severely diminished or extinguished ERG present at birth. So some etiology is it's usually present in 2 to 3 patients per 100,000 births. Males and females are affected equally, and it's the most common group of inherited retinal dystrophies after retinitis pigmentosa. It represents 5% of all retinal dystrophies and 20% of all children with visual impairment in special schools. So genetics, it's inherited in an autosomal recessive fashion, usually. So there's a couple different variants, 3 different gene variants, the OTX2 or the IMPDH1 gene, which are autosomal dominant, and then the CXR can be autosomal dominant or recessive. For LCA, there's several genes, at least 29. This kind of varies between the sources that have been identified, and there's still several causes that are unknown. I'm not going to go through that whole list, but you can see quite a few there of different genes. The most common is the CEP290, which is 15%. And then the GUCY2D is 12%. The CRB one is 10%, and the RPE at 65 is 6 to 8%. Those are the most common ones. And there's also several phenotypes. So kind of hard disease to pin down because there's several genes and then several different phenotypes as well. So this is just a picture from the BCSC, just kind of representation of how uncommon, unknown kind of mutations are the major majority, and then these 3 common ones here. And then just, again, a sample of all the different types of LCAs, the different mutations, where it's located, and everything like that. So again, several different types. So the pathophysiology, it's due to genetic mutations, a couple different things. Usually the eye is unable to undergo phototransduction because it interferes with genes that encode for the proteins that catalyze the generation of 11-cis retinal. Some variants can also interfere with the overall development of the photoreceptors. And retinal histology reveals involvement of the outer retina and photoreceptors. Some literature says there's an absence of photoreceptors. So probably depends on which variant you have. So signs and symptoms, you're going to see an abnormal or absent pupillary response. You can also see keratoconus in these children or keratoglobus, and that's usually secondary to the oculodigital phenomenon, which is just these little kids kind of poking or pressing, rubbing their eyes with a knuckle or finger to get some type of visual response. Nystagmus can also be seen usually early in life. It can also be present from birth. It can be peduncular or roving, and it's present in all positions of gaze. Another common symptom is photophobia. You can also get decreased night vision as well. And pretty significant vision loss usually ranges from 2200 to complete blindness, and vision is usually 2400 or worse. And then this is just a cute little picture of the little kids rubbing their eyes. Hyperopia is also commonly found, but myopia has also been reported. It's usually high hyperopia, usually greater than 5 diopters, which is thought to be from the impaired ametropization, which is the ability of the eye to accommodate to visual stimulus. So it's just a consequence of early onset visual impairment. Some different variants can also have non-eye features like intellectual disability, types of issues with smell, or types of different type of movement issues or behaviors. And then overall, 1/3 of individuals with LCA will have no perception of light. And then you get that irregular pupil response where the pupils are usually sluggish and they can be paradoxical. And the lenses can also have some cataracts as well. And then just a little bit, I'm not going into each of the different types of Lebers, but since our patient had type 9, and then there's one other type I'll talk about because it's the most important one in regards to treatment. So our patient had Leber type 9, which is the NMNAT gene, which has been shown to cause severe and rapid progression and macular degeneration, as well as central atrophy. You can also get congenital macular colobomas in this type. And usually you can get, unusually, you can get early onset atrophy of the optic nerve as well. LCA type 2 is an important one to know because it's pretty much the only one that has a treatment, which we'll get into in a second. So LCA type 2 is a RPE 65 gene mutation. This is the enzyme that normally isomerizes and hydrolyzes the all-trans retinal ester to 11-cis retinol. So in this case, you have relatively good vision in early life. You'll have significantly reduced night vision, mild nystagmus if it's present at all. And the fundus exam, you'll get this blonde fundus appearance with whitish drusen deposits in about 90% of cases. Later in life, you can get chorioretinal atrophy, peripheral patches in 64% of cases. So the fundus exam on this is very, very wide variation depending on the type. The retina can appear normal, or it can appear normal and early in life and then later have a variety of abnormalities. You can get this chorioretinal degeneration and atrophy around the fovea, kind of like we saw on the left eye of our one patient. This bone spicule-like pigmentation, which our patient had as well. A subretinal flex and kind of this marbled fundus, which I feel like our patient also had. And then you can get pigmented lesions at the level of the RPE, optic disc abnormalities, pallor, which our patient had some pallor, and vessel attenuation as well. And then here's an example. It's very poor quality, but this is from the BCSC of just a marbled type fundus look. And then diagnosis, two things, it's genetic testing and ERG are kind of the main go-tos for this. So genetic testing will confirm the diagnosis and help identify any specific mutations, which is again important because one has treatment. So if you identify that cause, you can send the patient for treatment. ERG will have absent or reduced electrical activity, and ERG is essential for the diagnosis of LCA according to BCSC. So in 2017, the FDA approved Luxturna, which is used for the treatment of the RPE65 mutation associated with LCA type 2. It uses an adenovirus to deliver the gene to the RPE. It only accounts for about a minority. We said 6 to 8% of patients with LCA, but is the only one that has FDA approved treatment. You'll get sequential and bilateral injections of the Luxturna, and each eye will do separate days, but no fewer than 6 days apart. So you do it in one eye, and then within 6 days, you'll do the other eye. You also give systemic steroids when you're giving this as well. The evidence of this was based on a phase 3 study, which were 31 participants and was changed from baseline to 1 year. And it basically looked at their ability to navigate an obstacle course around various light levels. And the patients who received Luxturna demonstrated significant improvements in their ability to complete that obstacle course. Some adverse reactions were just conhyperemia, cataracts, increased intraocular pressure, and retinal tears. This is just kind of the injection apparatus. It's subretinal, and here's kind of how you do it here. And then here's where the tip of the actual injection cannula would be placed from the surgeon's point of view. And then management, there's a couple additional gene therapies that are underway, but not quite approved yet. Supportive measures are also something that you can do, like if they have any type of photophobia, decrease the lights, and referral to a low vision specialist, special schools, things like that. Just a couple, these are the most current ones that I found that are being trialed. So for LCA type 1, they're looking for gene therapy. I think this is being done at UF. 9 patients have gotten this, and they've shown improvements in retinal sensitivity and their ability to navigate that low light course. LCA type 5 is going on at the University of Pennsylvania, just looking at mutations in the gene and some medications to address that. And LCA type 6, they're looking at an adenovirus type particle as well to help with that. For follow-up, they just said close follow-up with fundus exams and indirect exams, genetic counseling for family members, as well as carrier testing for at-risk family members if they're considering like conception. So during prenatal testing, something to consider. And then prognosis is very variable. It depends on the subtype. So there's several genotypes and phenotypes. It can be stable, progressively decline, or have some improvement in 10% of cases. And that's all I have.
Nice, that was lovely.